Thank you for joining us, and thank you for your patience as we worked through a few technical issues. We are presenting today a Lunch and Learn on cholesterol and your heart health, and we're working with Dr. Irving Schwartz to get the facts about cholesterol and learn more about how you can take control of your heart health. Before we get started, I think most of you saw the announcement about entering your name into the chat. If you're a Blessing employee, please enter your name there, and we'll make sure you get Core Health credit for joining us today. Dr. Schwartz, thank you again for talking with us. Can you just take a moment to introduce yourself?
Well, as you said, I'm Irving Schwartz. I'm a cardiologist. Been in practice 30 years. I have a particular interest in risk modification and prevention. So cholesterol is, one of our areas of targeting. So, yeah.
Okay. Well, thank you again for joining us, and we will try to allow time at the end for questions. If you have those, you can enter them into the chat, and we will try to get to those if we do have time at the end. Now, we've all heard of cholesterol, but let's start with some basics. What is cholesterol? Why is it important?
Well, it's a fatty substance that is in your body that, in fact, all the cells of your body have it in the membranes. And it's there, for membrane integrity and things like that. The reality is, though, your body makes it, so you don't have to. It's a nutrient that you don't have to eat. In fact, like a milligram a day is all your body really needs to manufacture it, and you'll be fine. On that basis, every animal is the same way. So every animal has cholesterol in their membranes of their cells, and thus lies the connection to our blood cholesterol levels that we're going to measure, because that's what we're measuring here. We're not measuring the cholesterol in the membranes. We want to know what's in the circulation, because the amount of cholesterol in the circulation has been very strongly associated with the development of what we call atherosclerotic heart disease, where the arteries develop what we call atherosclerosis, which are plaques, and it's filled with cholesterol, and they're inflammatory, and they are potentially dangerous because they can acutely rupture and lead to clot formation inside your arteries. And even if that doesn't happen, they can just keep building up and building up to the point where you get restricted flow through your arteries. So that's what cholesterol is. A fat. It's your cells need it, but your arteries don't. And the other logical connection to all that is, why are we getting cholesterol in our arteries? Well, it's because we're taking in excess amounts of it. We don't even manufacture a tiny amount. We're taking it in from food. Well, what food is going to have that cholesterol? It's the same food that's like us, animals that have cholesterol in their membranes, because otherwise it's not found anywhere else in nature. It's only found in animal foods. So
cholesterol, we naturally make it. We also get some from our diet. Let's break down a little bit further. We hear HDL, LDL. HDL is often referred to as good cholesterol. LDL is bad. What's the difference? Why does it matter?
So what they've discovered over the years is that you have specialized proteins in your blood that are involved in cholesterol transportation. So the first step, of course, is you eat it. You eat it in your diet, and you eat a piece of an animal, and you get cholesterol into your bloodstream. And now the transport mechanism sends it where it needs to go. So the protein that there are many lipoproteins, but the ones that we focus on is, as you mentioned, HDL and LDL. So LDL is the transport mechanism that carries these proteins to the periphery. They carry the cholesterol to the periphery. They take it to your muscles, to wherever it might be needed in the body. And so think of them as as these boats or train going outbound. And then the HDL is the transport that actually brings it back to the liver. So it brings it back for exit. So logically speaking, it makes sense. The LDL, or low density lipoprotein, that's what it stands for, is, you could also call it lousy, because it's the one that's making your arteries clog up, because basically it's taking all that excess you just took in with that bite of your hamburger, is going now to everywhere else. And well, everywhere else doesn't need it, because you only need a very little bit. A lot of it ends up in the lining of your arteries, and that's kind of the whole concept. So that HDL, we believe, is carrying it back in a way. So it's always good to everybody says it's good to have good HDL, or happy, or you want that to be the good, the high amount, and the lousy to be the lower amount. So that's basically how we look at it.
So kind of to summarize, it sounds like the HDL, the good cholesterol, kind of works like a magnet to collect the excess cholesterol in the bloodstream and help the body excrete it so that it's not in places we don't need it.
Right. That's why we always say it's better to have a high HDL and a low LDL. That would be your ideal lipoprotein setup, because it's one's taking it out and one's carrying it back.
So triglycerides are also a part of our total cholesterol number. What are triglycerides? What are they doing? And how do they contribute to that overall total cholesterol?
So it's another fat in the breakdown of fatty acid breakdown. So you'll get large amounts of triglycerides after a fatty meal, potentially too. It's linked, interestingly, to glucose metabolism. Sometimes people with high blood sugars run high triglycerides as well. And it's carried by a different set of lipoproteins in the blood. They're even smaller lipoproteins. So it's one of the subfractions of your cholesterol. And it's not usually directly, it's not if you took the sum of your HDL and your LDL and then you added the triglycerides, you wouldn't get the actual total cholesterol level. It's usually like 20% of your triglyceride level adds to that number. So that's how you get a total cholesterol number. So the overall magnitude of the triglycerides on that number is not, tremendous. But it is another, aspect of cholesterol metabolism, which, it has a lot to do with the fact that your body, can manufacture cholesterol from other fats, and triglycerides are part of that fat transport mechanism in your blood. So again, after a fatty meal, a lot of times your triglycerides will spike in the blood. That's another aspect of it.
So our total cholesterol is the HDL plus the LDL, and then 20% of our triglycerides, and that's how we get that number that we all see at the end of our screenings. Can you talk about what the recommendation is? What's the number, the ideal cholesterol recommendation? And when we see that number start to increase, we also see our heart disease risks increase. Why is that?
So so ideally, it's very interesting, because heart disease as we know it in our country, in this nation or in the Western world, is a disease really of the Western world. It's where people are consuming large amounts of animal foods. So the average cholesterol in our society, I can't tell you what the current numbers are. At one time, it was like 240, So way back in the day, they used to say, well, when blood tests were measured, were determined by the mean of the average person, that would have been the normal range, like up to 240, what used to be the normal for cholesterol. Well, we realized that's way too high. And if you go to many third world countries, like in Africa and even Asia, the average blood cholesterol levels are much lower, and that's because their diet's very different. So we started to set arbitrary numbers. We kind of said, well, 200 total is what your cholesterol, above that's high. Well, even that's probably too high, because if you look at what's called the Framingham study, where a lot of the knowledge we have on cholesterol and its relation to heart disease comes from Framingham, which was this little town in Massachusetts of 15,000 people that volunteered to be in a big nationally funded study after World War II. And they looked at every aspect of these people, and they all, and that's how we learned a lot about what these cholesterol levels, what was, determining risk. So people with the highest cholesterol levels in the Framingham study, in particular LDL cholesterol, had the highest risk of developing a heart attack or some cardiovascular event in the future. And these people have been followed now for 70. I think I believe the population is still being studied, but it's over, it's almost 70-year-old study. So that's kind of where we got the ideas about the numbers. But if you look at that study, if you had a total cholesterol under 150, they rarely ever saw a heart attack. So if some people believe, well, maybe 150 should be your goal, not 200. Practicality of that arrangement is probably one of the reasons why we say 200, because you would find a lot more people being pushed onto cholesterol medicine if you made the goal 150. So, and then there's like LDL goals, because like LDL is the big villain in all this story. So ideally, we say people should have your LDL below 130, would be the number that's arbitrary. Of course, all these numbers change if you already have artery disease, and then the numbers are much lower. I mean, there's no limit to how low you should have it. And as a frame of reference, a newborn infant has an LDL cholesterol of 40. So think about that when you get your cholesterol checked, where you started from at one time and where you are now in your life. So yeah, that basically, I think that answered the question.
So you've mentioned a couple times now diet. What dietary recommendations do you make for your patients if maybe they're seeing their cholesterol levels increase and they want to try to lower those, or they're just trying to maintain their cholesterol level? So dietary recommendations, what can we do to maybe take control of our cholesterol?
So if you got my hint about, as referring to where cholesterol is sourced from, the more animal foods you're eating in your diet, is going to have a significant contribution towards your blood cholesterol level. Well, it turns out that's not the only part of the story. They discovered that saturated fat actually and trans fats are a significant contributor to total cholesterol as well. And so the more saturated fat in your diet, the greater your cholesterol will be, as well as the amount of total cholesterol that you're eating. So the guidelines, and I would tell my patients, to restrict your saturated fat intake, as well as your total cholesterol intake. Now, depending on who you ask and what agency, recognizing the fact that most Americans are very much attached to their foods that are high in cholesterol, they just urge people to limit it. So for example, I think the current guidelines suggest less than 200 milligrams of dietary cholesterol a day. Well, I think you get about 150 in one egg, so it gives you an idea, you're using up a lot of your, dietary daily guidelines. Now, ideally, I think it should be 0, because taking 0 is better than 150 milligrams or 200 a day. And I think the guidelines, people acknowledge that. So, but they try to make it compromise. Everything is kind of a compromise, and because they know it's not easy for people to give up their cholesterol in their diet. So, same thing with saturated fat. They recommend restricting that under, I think, what is it, like something like less than 10% of your fat calories should be saturated fat, if I remember right. So the less saturated fat in your diet, the better, meaning you should be eating more what's called monounsaturated fats in your fats. And those are things you'll find usually in many plant-based fats. Animal foods are highest in saturated fats, it turns out, as well. So, not just you get the cholesterol from, that hamburger, you're also getting the saturated fat. People in this country have cut back on red meat dramatically over the years because they heard red meat's bad, it's got saturated fat, and it has a lot of saturated fats. So now, like, chicken is the biggest consumed meat in American tables these days. But it's now the leading source of saturated fat in the American diet because there are people eating a lot of chicken. And remember, the cholesterol comes from the lean portion of the meat. It's not even the fat in the meat that has the cholesterol. It's in the muscle, it's in the tissue. The saturated fat, a lot of it's found in the fat of the animal. So the leaner the meat is still better because you're getting a little less saturated fat. But that's, another one of the, so I'll try to tell people to, obviously limit those foods. And now, people are recommended to consider dietary patterns, not so much like, cut this out, cut that out, and then what do I eat, So we kind of encouraging people, the idea is to eat a more plant-heavy diet, So the most popular one right now is probably the Mediterranean diet and recommendations. And there, people are encouraged to, replace butter, for example, with like olive oil and things like that, and eat more plants, basically. Maybe more fish, even because fish contains omega-3 fatty acids, which actually lower your triglycerides. That's one thing about fatty omega-3s as they triglyceride lowering effects. And there's some ample studies that found that fish eaters have a lower risk of cardiovascular disease. The lowest you'll find in people that are vegetarian or even vegan, even better, because vegetarians are still consuming dairy and eggs, but vegans will consume none of those foods. And the populations we've studied the most are like the Seventh-day Adventist in Loma Linda, California, where there's a very large Seventh-day Adventist population, and they are, for religious reasons, they're kind of encouraged to be vegan, actually, but only a small fraction of them really are. And but you could see differences in cardiovascular disease as you go from people who don't follow anything special to people that are just fish eaters, down to vegetarians, and at the lowest end of the spectrum are the vegans in terms of total cholesterol levels as well as cardiovascular risk. So we have a good understanding of that from that population.
So the more that you can incorporate vegetables, leafy greens, and decrease your intake of animal fats and processed foods, the better off you're going to be when it comes to cholesterol. What about exercise? Does that play a role in decreasing your cholesterol at all?
Let me just throw one more food idea into that. Increasing your fiber intake. We find that a high fiber diet will lower your cholesterol very well. And then nuts. Nuts are high in what they call plant stanols, which lower cholesterol. So increasing your intake of tree nuts and beans. Those are the foods that I, have the most dramatic effect because they're high in fiber and they actually directly lower your cholesterol level. So if you shift your diet, throwing those into your food, you'll do, and even seeds, do it too, like flax seeds and chia seeds, because they have omega-3 fatty acids. Back to your question on the exercise. So, the effect of exercise is on cholesterol levels is kind of, there's some effect. It's not, you're not going to lower your cholesterol. You can decide that you're just not going to change your diet. I'm just going to exercise. You're not going to see much of an impact on your cholesterol. You could raise the HDL. It's always, exercise has been touted as raising HDL. But it's hard. You got to put a lot of time in to get that to go up significantly. So I think exercise is great, and you need it for other reasons. In fact, exercise itself is preventative of cardiovascular disease and prevents events in people, and has so. But if your sole goal to lower cholesterol, you would end up being disappointed. I think most people would, by the amount of exercise they would have to put in to see those effects. But you should still exercise because you're going to get other benefits that are not so much cholesterol related.
So we know that for some people, medications are end up being their best option for lowering their cholesterol. But oftentimes when people are prescribed certain medications, you hear them talk about maybe unwanted, not necessarily side effects, but they complain that they feel achy, or they just don't like the way the medication makes them feel. What do you recommend in those instances?
Well, my first thing, is to make sure you really need to be on medicine. I say that because, sometimes just because your cholesterol is high doesn't always mean you should be on pills for it. If there's a calculator that hopefully the doctors are using to make those decisions, and the simplest one was a Framingham calculator. We're using now what's called the ASCVD calculator, and it factors in your age, your gender, whether you smoke, blood pressure. It factors in everything but family history, which is maybe an important issue in its own right, but it doesn't look at that. It looks also at race to the ASCVD calculator. Anyway, if you're not in a high risk by the calculator, theoretically, you could avoid medication for at least the immediate future because, your cholesterol may still be high, but your risk factors overall don't really warrant medication for you. So that's always the first thing I would talk to people who are having difficulty with it. But let's say, okay, you need it. Let's say you're in the higher risk category. People sometimes get by on a reduced strength of a statin. So statin drugs are the most popular drugs, and they're for good reason. They're well proven. They will reduce your risk of death if you have cardiovascular disease, without a doubt. Best bang for your buck you're ever going to get. But in a primary prevention role, in someone who's never had a coronary disease and their cholesterol is just high, that's where there's more controversy because, like I was saying, just because your cholesterol is high doesn't mean your arteries are plaquing at the stage of your life yet of any significance. So, like I say, work on the lifestyle. We just talked about the food changes to diet. What can have a major impact on that number. But okay, let's say, you tried everything and you go on a drug, you're having side effects from a statin drug. There are other drugs out there now that are not statins, and they range from the inexpensive, such as things as ezetimibe, which is just helps you malabsorb some cholesterol, to something called bempedoic acid, which is not a statin, not as strong, as statins either. Neither one of those two drugs are as strong, but together they're actually fairly potent. And there's a combination pill, and then there's the PCSK9 inhibitor injections that we have, and now we also have a new one that's a twice-a-year injection that people get in the office, and that's also very extremely potent, by the way, but also extremely expensive. So, we try to reserve those to the people with disease and who can't, primary prevention, in a way. The British Medical Journal did a study on this, asked this very question. They asked, how many years do I gain by taking a statin drug? And they actually looked at the numbers, and they found that the average person gained 6 months of life taking a statin drug. Well, that's not that impressive. I'm not sure.
Not at all.
For 6 months, I'm not sure I would want to do it. But they drilled down further. They went and they actually broke it down. They actually found out the reality was actually 90% had no gain of life on a statin drug. However, like 7 to 10% gained years of life on it. Why? Because they basically were the highest risk people. And when you give it to the highest risk people, bingo, it's the best thing to be on. But for the rest of us, it's more theoretical, right? So that's important. And so that's led me also, what I try to do in my practice is try to focus down on people who really need it. So like I say, the calculator is one method that's supposed to be helpful. But even then, people with high risk on the calculator may not really be as high risk as we think. So I'll suggest to people consider doing what's called calcium scans or calcium scoring, which is a cardiac calcium scan. They just lie in front of the CAT scanner for 2 minutes, and it will tell you how much plaque buildups in your arteries. And that helps us focus on the people who are probably in that 10%, who it's going to add years to their life, versus to the other 90% where, may not make much of a difference. And maybe those are the people just better off just watching their diet, and eating it, which, by the way, is not just for the benefit of your heart. The same heart healthy diet that I just described of cutting down on animal foods and eating more beans, seeds, and nuts leads to lower risk of cancer too. We know this is not just a heart issue. the diet. The diet is also that same population I cited in Africa who has a very low risk of heart disease and very low cholesterol levels also have 1/100th the risk of colon cancer than we do in North America or the Western world. Again, a completely different diet. So diet patterns make more of importance if you're not, if you can't take a statin drug, you can't take cholesterol medicine, diet maybe does play more of a role, but for your overall health, not just cardiovascular health.
So I do want to we had a couple quick questions here. We will try to wrap up because I know everybody's probably trying to get to their lunch, hopefully a heart healthy lunch. We did get a couple questions from some of the people joining us. So this one is specific to that more plant-based diet that you talked about. The question is that they have heard many plants have toxins in them. So are there plants that they should stay away from?
So, that's largely, I mean, yeah, there are poison mushrooms out there, and there are foods you shouldn't eat. I'm picking up the vibes. There's a cardiac surgeon out there who I see on the internet a lot, who talks about something called lectins that are found usually found in beans in particular, and he thinks they're like awfully bad for everybody. You should avoid them like the plague, but there's no evidence that supports any of the claims this guy makes. In fact, all the evidence suggests a high legume diet, which is where lectins are found, by the way, is associated with longevity. And I could show you there's so much evidence on that. But more importantly, too, most lectins can be, if you're worried about it, they could be cooked away. If you thoroughly cook your beans, for example, what comes to mind are red kidney beans. Are particularly high in lectins. If you eat them undercooked, you may get sick from them. There are people reportedly getting. So well cook your food. I think that's largely a myth. Individually, there could be people who have more sensitivity than others, and I can't speak for individuals, but we can speak for the general population. Don't be afraid of them.
So I think that diet that you're talking about, I think it was made popular by Tom Brady. I think he's the one who does that diet where they don't eat any lectins and things like that.
Yeah, that's his name.
Yeah. One other question here before we wrap up. And I think you kind of touched on this one earlier as well. Can your total cholesterol levels ever be too low? This individual has had a duodenal switch and noticed that their levels continue to drop since surgery.
Well, that's great. Actually, the lower the better. So there's there's an old myth about, it was widely held for many years that the lower your cholesterol was, it may not be so good. There was like as it got lower and it reached a point where it's actually now deadly. And there was studies that showed that, because you looked at populations who had the lowest cholesterol level in this country, that is, had a higher mortality, and they're going, well, that can't be good, right? Well, until you break it down, think about this. In this country, on a natural, most people eating a natural American diet do not have very low cholesterol levels, so they there's a reason why their cholesterol is very low. It's probably because they're not eating, and they're starving. So why are they not eating? They're sick, and they may have cancer. They may have other conditions. So yeah, they're going to die because they got other conditions and their cholesterol is very low. It had nothing to do with the low cholesterol. The low cholesterol is a result of just not eating. And by the way, the best way to lower your cholesterol, if you ever want to cheat, is to starve yourself, for like a week, and your cholesterol will get really low. But you didn't hear that from me. But the point I'm making is that we now know, and there's now many studies that are coming out showing that the lower the cholesterol, there's absolutely no harm. And there's been concerns of cognitive decline because the brain is loaded with cholesterol. That's where a lot of your cholesterol is in your brain. So they thought, well, maybe you're going to cause brain problems, and that's not panned out with the new drugs that are out that you give them on top of a statin. We're getting the lowest levels of cholesterol we've ever seen in people, and we're not seeing any decline from that.
For that lunch and learn today.
Oh, sorry, we're hearing somebody speak. So if you are on, if you could mute your microphone. Sorry.
So we're seeing no harm from that. There's no signals of any harm at all coming from it. And we think, so I would enjoy the very low cholesterol level. That's how people in studies actually have regressed their disease in their arteries. You can regress the plaques that you may have built up, from a lifetime, can start to go away if you get your cholesterol as low as. So no fear of that at all, and enjoy knowing that your arteries are feeling better because you're breathing freely as you get rid of the plaque and cholesterol.
So we got a couple more questions here. One, actually a couple of them about diet. This individual's heard oatmeal is supposed to help with lowering cholesterol. What are your thoughts on that?
Yeah. Again, it's there are a lot of high fiber grains like oats that actually will have lowering effects. Absolutely. So, and you can make it even better by throwing in like some, maybe some flax seeds or some walnuts in your oatmeal, and you could make it even more cholesterol lowering. So yeah, absolutely. Oatmeal is a good food for any high fiber food is going to be good, and oatmeal is particularly good.
Another diet question: how would an only protein diet relate? And I think you touched on this earlier as well, but we'll go ahead and make sure we get that answered.
Yeah. So if you're only, well, first of all, only protein, it's got a lot of issues. It's very hard on your kidneys, for one thing. Your kidneys metabolize protein, and there is danger of eating excessive amounts of protein, even though most Americans are eating excessive amounts of proteins because out of fear of some kind of protein malnutrition. Really, the only malnutrition I see among my patients is fiber malnutrition. People are not eating enough fiber. You're not pooping enough, and you need it for gut health. Fiber, and that's found in the plant foods. So yeah, so that's the problem with like. And then I was going to say, well, where's your protein coming from? If it's plant-based, you're probably getting a good balance of protein. You're eating beans, you're getting a high protein diet with fiber and other micronutrients. If you're eating nothing but meat, whether chicken or, even just pure fish in your diet, you're missing out on everything, including fiber. And so, you might be eating leaner by doing that because you might not be eating, other fats and stuff, but it's not the solution. It's not a healthy solution, in my opinion.
And one more question here before we wrap up. What about CoQ10 for people taking statins?
It's a controversial subject, and the reason it even came about was, there's about 5% of people that get the muscle aches that you alluded to earlier taking a statin drug. So these people started to theorize, well, maybe it has something to do with CoQ10, because it turns out CoQ10 is transported by LDL. So when you take a statin drug, your blood CoQ10 levels are dropping because basically, you're reducing the LDL in your blood, and that's for the transport of CoQ10. So that people postulated that, well, maybe by supplementing CoQ10, you're going to alleviate, maybe that's what the problem is. Well, it's never been proven. I'm not aware of any study that shows, consistently shows there's a relationship between the muscle aches and CoQ10. So I'm a bit of a skeptic on it, although I don't, I wouldn't say it's impossible based on the mechanism that's been proposed. It's just yet to bear out. And think about this: if your LDL levels are low, and you take an extra CoQ10, I don't know if it'll help it get where it needs to go either, if that's really the mechanism, and I'm not really so sure. And from my own experience with patients taking it, I've seen a very mixed picture from it, which tells me that some of it could be either real benefit or it could be the placebo effect, and it's very hard to know. So different doctors have different recommendations. Some of my colleagues recommend it. I just don't routinely recommend it. I'd rather just deal with the issue.
Okay. Well, a lot of good information today, and I appreciate everybody joining us. If you entered your name in the Q&A, we do have those, and I can see those. We just didn't publish them all, so hopefully it wasn't blowing up everybody's chat throughout the live event. We appreciate your time. We will try to get this recorded version available for anybody to watch after the fact. Is there anything else that you want to add today, Dr. Schwartz? Anything that you feel is important that we missed?
I think we covered everything. I mentioned the idea of the calcium score. We made a special effort at the institution to make it available and inexpensive, because a lot of insurances won't pay for this test. It's a screening test. But it's interesting, it's useful if let's say you have a normal cholesterol level but you have a bad family history, and your doctor doesn't think you warrant cholesterol treatment because of that, or getting a scan after age 40, it's usually useful after age 40. You discover if you're really higher risk than you thought you might have been, or the other way around. I've had, it's been recommended in the guidelines, if there's controversy, maybe you should take a cholesterol medicine, maybe you shouldn't. Doing a calcium scan, can actually tell you whether you should or not. Because if you have no buildup at all, you could just continue following a diet, based on what I've said. So yeah, I always like to mention that it's becoming a valuable tool for people to help decide their treatment. And then everybody should, background, always eat a healthy diet for the reasons I mentioned. It's not all about your arteries. It's about brain function. It's about cognitive decline in old age. They find people eating the healthiest diets have lower cognitive decline in old age. But possibly too because of your arteries. Remember, your arteries are your roots, like a plant, right? So, and that's one other thing that we didn't touch on too, is that what you eat does affect your arteries directly, whether your cholesterol level is high or not. Your artery function is directly related to what we expose it to. And certain, these fats that we were talking about, saturated fats and cholesterol, are not, your arteries don't like them. They tend to they can constrict under exposure. So after that cheeseburger you just ate for lunch just now, your arteries might be very constricted and your blood flow isn't as optimal as you'd like it to be. And compare that to after eating a nice, salad or something, or maybe a bean burger instead of a hamburger. Your artery flow is going to be better after those things. And those are measurable too. There's something called endothelial function measurement tools that you can actually see. It's called brachial artery reactivity testing. And after a fatty meal or smoking a cigarette, like the flow down your brachial artery, it gets cut in half. I mean, literally. And that's just after, single exposure. I'm not talking about eating this their whole life. So it can actually, transiently do that. So think about it, every bite you put in your mouth, every decision is a step in for good health, and we all indulge, we have, indulging is part of living, I guess. But just keep that in the back. Indulging 7 days a week, versus 1 day a week, maybe 2 days a week, but eating healthy the rest of the week does more, a lot to help improve your artery function and overall exposure. It turns out to cholesterol is cumulative over a lifetime. So, having a good spurt of eating good for 3 months and then going off your diet because of whatever reason, you still did yourself some good. You didn't hurt yourself. Don't beat yourself up. So anything we do that's good for us, take every opportunity to do it, and then don't feel guilty after you indulge. And just remember, tomorrow is another day for opportunity to eat healthier and be healthier.
Well, again, thank you so much for joining us today. We appreciate your time and great information to kick off Heart Month. So thank you so much.
And thank you for having me.